My name is Michael Knukin. I am the Health Policy Director at the Fiscal Policy Institute. We're in session two of our summer Medicaid boot camp. Last week, we covered sort of Medicaid in general. Um, and this week, we're going to cover long-term care. And then next session is going to be sort of Medicaid esoterica, mostly hospital safety net hospital funding, complicated financial maneuvering, and Medicaid waivers, which are going to be in the news. And then session four is going to be more of a general introduction. Margaret had a great idea of just if folks are at a computer or able to, if they can just put in the chat sort of what their name is and their organizational affiliation, if any, or just sort of what made them want to show up. I would appreciate that. Um, this is a big topic, and it's a topic that's near and dear to my heart. I got my start in Medicaid policy as a union researcher for a healthcare union in Pennsylvania that mostly represented home care and nursing home workers. So I got my start studying long-term care. And I want to talk in this class about, in this session about what long-term care is, why Medicaid wound up financing it instead of just, for instance, Medicare, um, and then do sort of a deep dive into New York State's Medicaid long-term care program, which has been the subject of a wide variety of constant controversies, both for its entire existence and also in the last 6 months. So we're going to start general and historical and get into the nitty-gritty over time. But just to start, as we covered last week, Medicaid is a huge program by enrollment and by spending, but it's sort of huge for different reasons on each side. The vast majority of people who are enrolled in Medicaid are, non-disabled adults and children who are getting health insurance from the program. But a huge share, more than half of the spending, is for the relatively small share of Medicaid enrollees who are elderly and disabled and who are receiving long-term care. Not all the spending that goes to the elderly and disabled is spent on long-term care, but the largest chunk of it probably is. So we should start by just talking about what long-term care is. People are described as needing long-term care when they need help with activities of daily living for an extended period or indefinitely. So activities of daily living is a formal concept in Medicaid and disability world. It includes bathing, dressing, grooming, eating, using the bathroom, and moving around. And we also talk about instrumental activities of daily living, stuff that you don't need to do just to survive, but you need to do to live your life. Stuff like cooking, shopping, managing your money, stuff like that. Um, and so long-term care is the support people need to manage their ADLs. It is usually physical and it's non-medical. I don't really know what non-medical means, but it's usually not provided by doctors or nurses, but by workers with fewer credentials who make a lot less money. The examples here you can see stuff that help with bathing and dressing. And long-term care is physically and emotionally demanding to provide. It's emotionally demanding for all the reasons you would expect. I would just emphasize that physically, lifting a person from the bed to a wheelchair or on it or off the toilet is no joke. Nursing home CNAs actually have one of the highest levels of occupational injury in among all jobs, right? They're up there with like deep sea fishermen and loggers, right? So it's really, really demanding. You're lifting and carrying people every single day. Um, And so, who needs long-term care? I want to make a distinction here because, everyone might need help dressing, maybe if they had broken their arm, or they might need help eating if they get really sick. And of course, babies also need help with all the ADLs. I mean, you look at this ADL list and you're like, it's just a description of childcare, except for the managing finances part. But we talk about long-term care when someone needs long-term or indefinite help with their ADLs because of a physical, intellectual, or developmental disability, and very often because they're just old and have all of the physical and sometimes mental disabilities that come with being old. Um, and so even though, as a Medicaid wonk, I always say long-term care is for the elderly and people with disabilities. Like by enrollment, there are just a lot of old people who need long-term care. The majority, almost 70% of people who turn 65 today will need long-term care of some kind at some point in their lives, and often for an extended period of time, right? Someone gets old enough that they're no longer able to safely take a bath by themselves, and might live a long and satisfying life like that, or be in that state for years. And so this is long-term care is something most of us will eventually need. How do people get long-term care? A, a lot of long-term care is provided on an unpaid and informal basis, often by family members, often by female family members in particular. There's a little joke in the policy community that the best form of long-term care insurance is to have a daughter. Um, so a quarter of adults provide some kind of long-term care. And often this is something that happens to people. People become family caregivers late in life when a spouse or a parent needs it, right? Because the people tend to need long-term care in late old age, right? Like when they're over 75. And so their children might be themselves well into middle age when they start providing that care. And then a separate category of long-term care is paid formal care, right? So the two major categories here are nursing homes and home care. Um, and and so you can move to a healthcare facility where this care is provided, or you can receive this care in your home from a home care worker. And while many people pay out of pocket for these services, they're extremely expensive. So most long-term care in the US is paid for by Medicaid. Extremely expensive and not covered by Medicare. I want to just run through some terminology with you all. Long-term care is what we said. Long-term supports and services is like a little bit different, but pretty much when people use the two acronyms interchangeably. A nursing home is a skilled nursing facility. That's the regulatory category. And it's called that because it always includes quote unquote skilled, meaning credentialed nursing care. In addition to those like hands-on activities of daily living help, there's also going to be an RN or an LPN who will help you with your Medicaids, who can do injections, stuff like that. So that's nursing home. I think we, in our collective minds, have a vague category of like an old people's home, right? And that category includes assisted living facilities, which are different, less medical, more residential, usually not covered by Medicaid, although in some cases they are. But a nursing home proper is like a medical institution with RNs on staff. Home care and personal care are assistance with activities of daily living provided by a quote unquote non-skilled, by which I mean non-credentialed and low paid caregiver, often like an aide. Nursing home CNAs are also in this category, home care worker. Um, And then home health is usually a separate category and refers to like skilled more medical care. Um, and weirdly, in New York, home health aides are the ones who provide most of the personal care. But for the most part, when you're reading the policy literature, home health is like when an RN comes to your house and like um, injects you or sets up an IV or something like that. Whereas home care is hands-on care with activities of daily living. All right. So most of the people who need long-term care are elderly, and the US has a healthcare program for the elderly that is called Medicare, but bizarrely, Medicare does not cover long-term care. For the most part, Medicaid does. Um, and so Medicare pays for health care for elderly and many disabled people, but so when they go to the doctor or the hospital, that will be covered by Medicare. But if they need the kind of long-term care we've talked about, then for the most part, they either need to pay out of pocket or enroll in Medicaid. Um, and so the result of that is there are a lot of people who are on both Medicare and Medicaid. They are called dual eligibles because they're eligible for both programs. But really, it means dual enrolled. People who are enrolled in both programs are called dual eligibles or sometimes just duals. And so that will come up in the policy in the literature a lot. Um, and let's see. Um, the and so this raises the question of like how did we get here? Like why do we have such an idiotic program design where a huge category of the care that old people need is not covered in the old people program, but instead in the poor people program? It's a great question. And I had to read a whole book to find out the answer. And the answer is dumb. I read Bruce Vladek's Unloving Care, which is a great book about the nursing home industry, covers this really well. But the answer is dumb. Medicaid long-term care, or Medicaid ended up with the long-term care portfolio as an afterthought. So before the advent of Medicaid, most elderly people who needed, um, could folks, someone's drawing on the slide. Go figure. Um,
It's,
all right.
it's
Um,
funny.
be, that's all right. That's all right. It adds something. Before the advent of Medicaid, obviously most old people who needed care and most people with disabilities received care at home from a family member, but some were poor, or, either too poor, for, their families were too poor to provide care, or they didn't have any living family members, and they lived in, the county old people's home, which was sort of adjacent to the poorhouse or the same facility, or they lived in like a private, nursing boarding house type thing. And many of these people were low income, so they required state assistance. And so when Congress was sort of looking at designing Medicare and Medicaid in 1965, it didn't want to create an open-ended long-term care benefit within Medicare, but it said, well, for those old folks who are already wards of the state, we'll let the state cover their care out of Medicaid. Um, and as there was strikingly little sort of discussion or consideration of this. The history of U.S. long-term care policy is full of these moments when policymakers sort of dramatically underestimate how many people might need long-term care and how much long-term care is happening informally, and so make these sort of decisions to create a program to pay for it without any consideration of like how much of that they're doing, how expensive it's likely to be. And so Medicaid just sort of allowed states to pass off some of this funding and to create new sources of funding as an afterthought, without, I think, ever really clearly thinking through what problem we're trying to solve and what population we're trying to address here. So, just for instance, right, like one thing you could think about Medicaid long-term care as solving is the problem of care for elderly and disabled people who do not have any family members who are willing to provide care. I call this an orphanage model because the parallel would be, you know, for the most part, what should happen is that children are cared for at home, but then some children don't have parents, and so the state steps in and puts them in an orphanage or a foster home or whatever. So that's one model. The alternative model is that the state could have a much bigger role. We could say, maybe in the past, back on the farm, people who needed help with ADLs could rely on family, but now we have women in the workforce. We're more mobile. We don't always live near our family. The government needs to step in here and take on a really big part of this care burden by paying for it. I think Medicaid in 1965 and Medicaid today are not sure what they're trying to do with this. Sort of which is the model. And a second question is what is the population that sort of needs long-term care, right? You want to set up a government program, you have to decide who's eligible based on need. But anyone with aging parents knows that there is like a huge spectrum of level of need within long-term care from people who you might be a little nervous that they might fall in the shower at some point. You might think it would be great to have someone there to check on them, but mostly they're fine on their own, to people who are completely bedbound and unable to feed themselves or dress themselves, right? And so on that spectrum, when we say someone needs long-term care, where are we drawing the line? Um, and then the second question is, Medicaid was originally sort of agreed to take on long-term care for the poor with the idea that, middle class and rich people would pay for their own care. But long-term care is hugely, hugely expensive. And so the result of that is that if you start paying for long-term care out of pocket, you become poor very, very quickly. And so then is that sort of the intended result? Do we want to force everyone to impoverish themselves at the end of their lives if they need long-term care? Or is that sort of an unhappy accident? Right. So in the idea of making a a distinction among populations based on a need for long-term care is very fuzzy around the edges. And the idea of making a distinction among populations based on sort of income and funding is conceptually challenged by the fact that people are becoming poor as they require long-term care. So these policy problems, these questions have haunted Medicaid long-term care from 1965 to the present. They're not solved, and at the end of today's session, I'll have something to say about where New York is with them now. But just to say, these are one of the reasons this area is confusing and complex is that policymakers have never really decided for themselves what they're trying to do. Um, but to the point about people becoming poor, long-term care is really, really expensive. And it's expensive because it demands an enormous amount of one-on-one, non-automatable human labor, right? So whether people are in a nursing home or they're being taken care of at home, you can only, lift or help to eat or help to use the bathroom one person at a time. It's demanding, even though long-term care workers often make very low wages, even so, a significant amount, the paying for that labor is very, very expensive. And so nursing home and home care nursing home care fundamentally costs $140,000 a year and can be more. And home care, if you need a lot of home care, especially, can be over $100,000 a year very easily. And the result of that is that long-term care burns through people's life savings very quickly. And so it's extremely common in the US, everywhere in the US, for sort of people from a middle class background who had employer sponsored insurance their whole adult lives, who never, were on a means tested program before, to become Medicaid eligible as they pay for long term care and spend down their savings. And that makes Medicaid a really strange benefit and social program within the US sort of social welfare state, in that a huge number of the people who use it are sort of from middle class families and middle class backgrounds, but wind up on Medicaid usually to their own surprise at the end of their lives. The And so most Medicaid long-term care recipients are dual eligibles, as I discussed before. Um, all right. So Medicaid embarked on this project in 1965 of providing long-term care to some vaguely defined category of disabled and elderly people without really thinking through sort of what that would entail. And the specific form this took in 1965 was that Medicaid allowed states to create a funding stream with federal match for nursing home care. And nursing home in 1965 was not a very clearly defined category. Like, it sort of ranged from institutions you would look at and think, that's like a medical institution, like a hospital, all the way on one side of the spectrum, to more like boarding houses where maybe the woman cooking your food would also help you move around a little bit on another end of the spectrum. But suddenly, this tidal wave of federal money was directed at this vaguely defined industry, and because once the money was there, the industry grew up very, very rapidly and mostly on a for-profit basis. And so now, to this day, about two-thirds of the people in nursing homes are on Medicaid, and about 70% of nursing homes in the country are for-profit institutions. Um, Long-term care from the beginning was means tested with both an income and an asset test. So for someone to access the Medicaid benefit, a very typical scenario would be an elderly person would live on their own or with their family for as long as possible. And then maybe their spouse who was taking care of them would die or something like that, and they would need long-term care, and they would spend down their assets and go into a Medicaid funded nursing home. Um, this industry we created overnight via federal funding decisions had problems right from the beginning and still does. Basically, we're putting very, very vulnerable people, people who struggle to advocate for themselves, struggle even maybe to get around or get out of bed, and who are also socially isolated, usually in the care of for-profit businesses that sort of the thinner the gruel is that they serve their residents, the more money they get to keep. And so the nursing home industry has been plagued with horrible, horrible scandals about patient neglect resident neglect and abuse right from the beginning. I mean, there's like, if you go back and just do the timeline of nursing homes, every 10 years, there's like a massive scandal where old people are, being left to be, you know, chewed on by rodents and not fed or abused or drugged with psychotropic medication so that they can barely talk. And like it's really, really, really horrifying, bleak history. Um, the state and federal governments have done many cycles of sort of attempted regulation of this, regulating staffing hours, patient rights, resident rights, all that stuff. But we've never really solved this problem. You can go back in New York State a couple of years, and the Attorney General did a really, really good investigation into three of the worst nursing homes in New York State, and it makes really horrifying reading, and also shows that these for-profit actors can find a lot of ways to extract a lot of money. That said, these problems didn't stop nursing home growth because we're at this moment in the 60s and 70s where life expectancies are starting to extend really dramatically, and so the number of people who need this kind of care is growing, even as there's less ability to take care of them in the home. And so, one of the consistent tensions in nursing home regulation in the late 20th century was someone would say, we should really license these and like close a third of the nursing homes in the state because they're run by criminals. And someone else would say, yeah, but even the ones run by criminals have a waiting list of 20 people to get in. Um, so the problems with nursing homes were recognized very early in the growth of Medicaid long-term care, and by the 1970s, people were already talking about what are the alternatives here. Well, why should we make people leave their home and enter an institution run by criminals to access long-term care? Can't we send folks to their house to take care of them at home? Um, and the hope was that, um, you know, most of us on this call and most people in the world would much rather age at home where we control surroundings, where we have connections to our community, where we're not sharing a room with another person, maybe for the first time in decades, right? So home care is definitely something that a lot of people want. It's also arguably cheaper than nursing home care. So I say arguably because it really depends what the level of need is for a given person. If there's an old person or a person with a disability who needs just, a few hours of care a week, maybe help shopping, and then they can live safely at home, then it's much, much, much cheaper to provide those few hours of care than to move them into a nursing home. Uh, if someone needs round the clock care, then it's probably cheaper to provide that care in a facility where a lot of people are concentrated and one CNA can take care of more than one person. So that's sort of a complexity, and we'll have more to say about that. Um, in the national literature, the transition to home care is often talked about as something that happens like in the 90s and the early aughts. But New York has had Medicaid home care from way, way back. Really, since the Great Society, but growing rapidly in the 1980s. There were major New York City nursing home scandals in the 80s, and one of the policy responses was to broaden Medicaid eligibility for home care. So, um, and um, and so the sort of policy goal that was shared in New York by the federal government, by everyone else, was known by the sort of term of art rebalancing. So the idea of rebalancing is that back in the 1980s, all of the Medicaid long-term care spending was on nursing homes, and we want to rebalance that toward home care and spend more on home care. And this is a graph of how much we rebalanced between sort of 1980 and 2014, and all of the different people were just passing laws in Congress every 2 or 3 years, trying to find ways to encourage states to do more home care. There were federal bureaucracies tasked with checking whether states were doing enough home care. Home care has been sort of the consensus long-term care policy, and fairly bipartisan for decades and decades. So I want to sort of set that context. The big kinds of Medicaid long-term care, home care has been the policy preferred one for a long, long time. And for that reason, states all over the country and New York have shifted a lot of money into home care. So so home care sort of in the era when everyone loved it sort of got, you know, it looked like a win-win, right? Because everyone wants home care more than nursing home care, and also you say it's cheaper. Wow, like what more could you want? And and so the and so that was a very powerful political argument. But in I'm very skeptical of the home care is cheaper on a system-wide basis argument. And I think from very early on in this transition, like you can read reviews of the literature in the 1980s saying home care is we hoped home care would be cheaper, but this study shows it isn't. And the reason for that is home care isn't a one for one replacement for nursing home care. It's not enough to just say, like we transitioned this person from a $150,000 nursing home to a $40,000 home care situation. We saved $110,000 because home care is way better than nursing home care. More people prefer it. And so if you add a home care benefit, what you find is that rapidly, even if you're saving on each person who's transitioned from a nursing home to home care or who went to home care instead of a nursing home, you have many, many more people who are seeking long-term care. Um, and so home care is great, but it does not necessarily save the system money. And I'll have more to say about that when we talk about New York specifically, which here we are. And I'm sorry, I saw a hand raise. Trina, I think you raised your hand.
Yes, I did, but I don't want to get us off track. I just wanted to add this other element that's kind of in the background of all of this history, which is like a more, I guess, cultural, historical, civil rights push for deinstitutionalization, um, and a lot of funding and programs and efforts at the federal and state levels to work with rebalancing. Money follows the person. Community first choice option, which encouraged states to rebalance their institutional level of care. I'm a disabled person who also has home care, but I'm a policy wonk too. And so the world I exist in is constantly in this framework of institutional care versus home and community-based services. And it's this kind of like I need help getting out of bed in the morning, getting dressed, and getting showered, and looking like I do, so I can be in front of my computer and do what I need to do. But um, in some ways, it is cheaper to keep me in the community to do that. But when my needs change, it's, I guess, more effective to keep me in institution. Yet I do have civil rights. What I'm saying is there's this
Yeah.
other dimension to the story, which is that the dichotomy between institutional and community, and even Medicaid is set up this way. Institutional Medicaid versus community Medicaid, which one are you applying for? You know,
Wait, so Trina, I'm really glad you're raising this, and it makes me think of something I want to say, and also I want to keep moving with my
yeah.
presentation. But you're bringing like my presentation of this whole history is like very, very biased toward Medicaid long-term care thought as elder care. There is a really important dimension of this history, which is about non-elderly people with physical disabilities and other kinds of disabilities fighting for their rights to care and to care that respects autonomy and choice. And I think it's a really interesting history in part because like a lot of the wins that the and civil rights expansions that the disability rights community accomplished within Medicaid actually came to benefit elderly Medicaid recipients as well. And so that's an important dimension. And I'm sorry that this presentation will continue to be a little tilted toward elder care, but we'll see what we get through. And for other folks, since we're a smaller group today, which is great, and also no longer webinaring, if you have a question, just being respectful of us moving through the class, but if you have a question or a comment and want to use the Zoom raise hand function, then please feel free to do that. I will not see you if you raise your hand in any other way, but if you use the Zoom function, I will see.
I just want to add that because home and community-based services is not like a right yet, and I want to say yet because I want to be hopeful, not in this administration, but maybe somewhere down the line. Because of that, these sorts of services, even for seniors, are really vulnerable to any kind of budget cuts in states when they're facing a lot of federal pressures. So
Yeah.
I just wanted to throw that.
No, absolutely. And yeah, we'll talk more about that. But so just let's talk about New York's long-term care program because I think with the history I just gave is probably basic for some of you, but I want to get into the guts of our program. So New York Medicaid operates the largest long-term care program in the country, driving a huge amount of Medicaid spending, about half of all spending. Uh, the state spends 25 billion a year-ish on just home care alone, and most of this care is sort of directed through a very poorly designed managed long-term care program. And for a variety of reasons that we'll talk about, both enrollment and costs of the long-term care program, and specifically the home care program, have increased rapidly over the past decade, which has driven a lot of conflict. And since we're going to be talking a lot about the gory policy details of Medicaid, I just want to talk about sort of the economic weight of and the employment market weight of this program we're talking about. So personal care, home care, which is mostly financed by Medicaid, is the largest employment category in New York State. There are over 660,000 New Yorkers working in home care as home care workers. As of 2025, that's more than double what it was 10 years ago. And it's, like a very, very large category of low wage employment. So, fast food is a big industry, but home care employs 3 times as many people as fast food. There are more than twice as many home care workers as retail salespeople. And home care workers in New York make more than in other states, but it's still a very low wage occupation. The BLS puts the median wage at 1958, which is about $41,000 a year, which is not remotely close to enough to sort of live independently in New York City. And that's an important dimension of this is that basically, to within basically all of those people work for the state government. There are a lot of intermediaries, right? Like state Medicaid pays managed care programs, which pay home care agencies, which pay the workers. But fundamentally, it's the state Medicaid program that is the largest employer of low wage workers in the state. And so that's some of the stakes of home care policy. So, and those programs are a really large share of all Medicaid spending. So this chart, don't pay much attention to the absolute numbers because it's state share rather than state plus federal spending, which I don't like to use. But the colorful slices on this chart are Medicaid long-term care spending. The big one is managed long-term care, which is mostly home care. The green one is nursing home spending, and then there are a few other categories. And the gray slice is everything else Medicaid does. So that's providing health insurance, it's paying Medicare premiums and deductibles, it's safety net hospital financing. You can see that basically half of the Medicaid program is just long-term care. So it's a really important share of the savings. And now I want to make a point about the scale of New York's long-term care program, and I made a chart. Sometimes you get too ambitious with your charts, and this is a case of that. The point of this chart is to say that New York both has a lot of people in nursing homes and also it has a huge home care program. Um, so if you're thinking about like the scale of a state's long-term care infrastructure, you want to compare it to how old the population is in that state. Because even though younger people with disabilities also use long-term care, a huge share of the users are folks over not only over 65, but over 75. And so you can sort of think, okay, how many nursing home residents are there per 1,000 people over age 75 in New York? And the answer is on the vertical axis, there are about 60 nursing home residents per 1,000 people over age 65, which puts New York not like in the really high Iowa, North Dakota, Louisiana sort of group over here, but it's pretty high. It's above the national average. And then second question, how many home care workers are there per 1,000 people over age 75 in New York? The answer is almost 400 per 1,000, which is, not only above the national average, but it's like way above the next highest state, which is California. There's a cluster of sort of DC and Minnesota, and then there's everyone else. So New York has like a larger home care program and a fairly large nursing home program relative to other states. There isn't, this goes to the point I was saying earlier about how there's not sort of a one-to-one replacement between nursing homes and home care. You read some politicians talking about it, you might think, like the more nursing home residents you have, the fewer home care workers you have, and vice versa. But New York just provides a lot of long-term care of both categories. And its home care program, it really, really stands out as being very large. This makes that point in a somewhat better way. It's the ratio of the blue line is basically home care recipients. It's technically MLTC enrollment, which we'll get to. And the green line is nursing home residents per person over 75 in New York. And you can see there were, about 6%. The number of nursing home residents went down absolutely and as a share of the over 75 population from about 8% to 6% over the past decade. So that's a modest decline and a success. And then home care enrollment really, really went up quite a bit. There was a pause during the pandemic, but then it sort of continued to rise. And overall, for every, in 2015, for every 100 people over 75, there were 12 home care recipients, and now there are almost double that, 23 home care recipients in New York. So home care has grown a lot. Nursing home enrollment has shrunk a little bit, and it's not really explained by aging population because this is kind of controlling for that. So another way to see the same thing over the same period, the New York's managed long-term care programs have grown from an enrollment around 140,000 in 2015, um, grew, had a brief sort of collapse during COVID, and then continued to grow until 2025. And overall, that enrollment has more than doubled. So this is sort of the policy context of like why there's so much politics around home care in New York is that the program has grown quite a bit. Um, So let's talk a little bit about home care, how home care is delivered in New York. And I want to talk about like the home care side and then the financing side. So the home care in New York, sort of how you get it day to day and then how the care is paid for. Um, so there are about 400,000 Medicaid home care recipients in New York versus about 70,000 Medicaid nursing home recipients. And home care is delivered through sort of two major wings. There's agency home care, where a home care agency known by the acronym LICSA, which there's a prize for anyone who can reconstruct what that acronym stands for, but it is pronounced LICSA. It is an agency that employs a bunch of home care aides and is paid by Medicaid. You call up that agency, you say, I need some home care. They assign you an agency worker who works for the agency. They schedule all that stuff. And then there's Consumer Directed Personal Assistance Program, CDPAP home care, which is where the consumer, the Medicaid beneficiary, uh, uh, selects an aide who is often, not always, a friend or family member. And the consumer sort of decides who's going to take care of them, trains them, schedules them. So it's more, you have more direction and more control. Now, if in the CDPAP program, the worker is paid through a business called a fiscal intermediary, which handles payroll taxes, keeping track of all that stuff. But they're sort of hired and directed and trained by the consumer themselves. Um, and sorry, my slide got out of order here. And CDPAP has been in the news and subject to controversy because it grew as a model of home care really, really dramatically in the decade after 2015 or so. So this is the dark purple line is CDPAP spending, the light blue line is agency spending. This covers 2018 to 2023 because that's when I could get the data from. You can see that CDPAP spending really almost triples over this period, while agency spending is pretty flat. There are a lot of reasons for that. But because of this growth, CDPAP has been the site of a huge amount of controversy within Medicaid long-term care discourse in New York. And so it's worth sort of just talking through the history there. So CDPAP is a great example of something that was won by the disability rights movement and then went on to benefit a much larger share of older, elderly New Yorkers and everyone else. It was a priority for the disability rights movement, not just in New York, but around the country, because it gives the consumer so much more flexibility and control over their care. And in New York, versions of CDPAP have been around since the 1980s, but they were really small, like to the point that the disability physically disabled, non-elderly sort of side of Medicaid isn't as big as the elder side. Like this sort of disability rights movement program was like quite small, fewer than 10,000 people as late as 2012. And then for various reasons to do with managed care, which we'll talk about, and also a liberalization of CDPAP rules in 2015, CDPAP grew really, really rapidly after 2011 and went from being way under 10% of all New York home care to around 60% by 2024. And again, CDPAP workers were paid through FIs in the early years, mostly nonprofit disability rights organizations, but in later years, as the boom took off, sort of more and more by for-profit FIs. So this is, in my view, like it's CDPAP is great, and it's great that it grew, but CDPAP sort of became the target of a lot of policy concern because it was growing so fast. And so just to sort of complete the history here, CDPAP has had a very, very rough past couple of years. The Hochul administration sort of saw CDPAP as the source of Medicaid spending growth, claimed in an unproven and sort of decorative way that there was a lot of fraud in CDPAP. And most importantly, the Hochul administration decided to do away with all of the many FIs, nonprofit and for-profit, that were operating the program until 2025 and pick one single statewide fiscal intermediary for the whole state and transition that in 2025. So now the whole program is administered by a company called PPL. And this transition was extremely, extremely, extremely disruptive to the program, leading to like all sorts of lost wages and confusion and people losing their healthcare benefits. PPL has just settled a $165 million wage theft settlement related to that transition. And so that's like the important recent history of home care in New York is politics around that. And to me, it looks like the CDPAP transition, all the disruption around it, and also the replacement of all those FIs that were aggressively advertising and so forth, really caused MLTC to stop growing in the past couple of years. It sort of flatlined, and so just to emphasize, right, like it's been growing for a decade. Now it has flatlined past in recent years due to this transition. Um, so I have had a lot to say in public and in private about how bad the transition was. And I still think it's bad. I think from the governor's perspective, the goal was to get the home care program to stop growing, and that has occurred at least so far. So just to review, right, like home care delivery happens through the through agency and CDPAP. But home care financing in New York is through a program called Managed Long-Term Care, or MLTC. Um, we discussed the role of managed care in Medicaid last week a little bit for mainstream Medicaid, and I talked about today sort of mainstream health insurance Medicaid is all administered by insurance companies. If you go to enroll in Medicaid, you sign up with Fidelis or Aetna or some other insurance company. The state pays a premium to that insurance company and they pay for your care, much like your employer pays a premium to an insurance company and they pay for your care. That transition was made in 1996, but long-term care, that part of the nursing home and home care part of Medicaid, was remained non-managed care, remained what's called fee-for-service for more than a decade after that. There were experiments, but there wasn't a full transition, and that's because doing long-term care, managed care is, as we'll talk about, depending on your perspective, either really hard to get right or simply a bad idea that should never have been invented. Um, but in 2011, the state, as part of Governor Cuomo's Medicaid redesign team initiative, the state decided to pursue mandatory managed long-term care. So everyone who was getting long-term care through Medicaid would be required to enroll in a managed care program. There were a couple of programs that were sort of not forced to transition into managed care. One of them is the Nursing Home Transition and Diversion Waiver, NHTD. But most of the long-term care happening in New York was crammed into managed care. And so what that means is when a beneficiary enrolls in, they need home care, they go to the state to enroll in Medicaid. They enroll with an insurance company, a managed care organization, or MCO. The MCO receives a capitation rate or per member per month of, about 50 or $4,500 a month, $5,000 a month, depending on the region and other factors. So that means for every single person in this program that has been growing so quickly, the state is sending $50,000 to $60,000 a year to an insurance company. And then the insurance company, the MCO, pays for long-term care out of this capitation payment. Originally, that meant all long-term care, including nursing home and home care. But in 2019-ish, they carved nursing homes out of the managed long-term care program. So now you have this crazy situation where, yeah, I know Trina's got me. The 2018, sorry, thank you, Trina. Now you have this crazy situation where if you need home care, you're enrolled in an MLTC program, but then if you end up in a nursing home, you get sort of transition back out and the state just pays for your care directly. So MLTC is this huge program, 400,000 enrollment, very expensive per enrollee, and it has not worked very well, in my view. But I want to talk about the theory behind managed long-term care was that it would control costs, basically. And you can be an optimist, and the reason it would control costs is like the insurance company is getting $50,000 or $60,000 a year, that's fixed. And then so its incentive is to prevent costs from, to try to save money so that it has some of that $60,000 a year left over for its profit, right? So it has an incentive to keep costs below the capitation rate for all its enrollees. You could be an optimist about how it might try to do this. Like it could be really thoughtful about addressing people's social needs and managing their care so that they don't have as severe health problems and they stay healthy and don't cost as much to care for. Or you could be a pessimist and just imagine that the insurance company is just going to try to provide as little care as possible. But either way, sort of the theory is that it will hold down care. In practice, this is just sort of not a well-designed program because MCOs get a capitation rate that is basically flat per enrollee. There's a little bit of what's called risk adjustment. So, you get an insurance company might get paid a little less for a healthy enrollee than for an unhealthy one. But basically, you can think of it as sort of a fixed rate of $6,000 a month. And then if they enroll someone or they have someone on their books who needs 100 hours of home care a week, then they're going to burn through that $6,000 a month really quickly and they're going to lose money. But if they enroll someone who only needs like 10 hours of home care a week, who's really pretty able and just needs a little help, then that will cost way less than $6,000 a month and they will make a ton of money. And so the incentive for the MCOs is basically to get as many relatively healthy patients into the program as possible while getting as many relatively unhealthy patients to go somewhere else as they can, right? So instead of sort of the MCOs facing like a fixed cost for a fixed population, they actually have an ability to hold that they have an ability to make more money by expanding the pie and especially by encouraging relatively healthy people relative to disabled and elderly Medicaid enrollees to join the program. And they also have an incentive to kind of aggressively deny care to people, right? Like if you have a client who needs 120 hours a week of home care, then your incentive as the MCO is to be like, no, 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 we're not providing that for you. Have you looked into switching to another MCO? Maybe they would be more willing to lose money on you. Have you looked into another program? And so it's this very dysfunctional set of incentives that tends to grow system-wide costs, even as for the highest need patients, it it causes a lot of care denials. And so, I just want to step back and look at the comedy of this, which is that in 2011, New York State decided to save money on its Medicaid long-term care program by going to managed care. What happened next was that its long-term care program grew by a factor of roughly three very, very rapidly over the course of that whole period, with only brief exceptions for COVID. And so we've really screwed up our attempt to save money as a state. So, but uh, we've talked about home care delivery, we've talked about managed long-term care as a program, and zooming back out, right? We have mm, a long-term care program that is extremely expensive by national standards, that employs a lot of people, that has many beneficiaries, and the question is sort of why, and are we doing something wrong? Is this a problem we should fix? I would argue that the reason long-term care spending is high and growing in New York is sort of like the opposite of a mystery, or like it has many very large, significant, and clear explanations, almost all of which are policy choices by New York State. So long-term care in New York has relatively generous eligibility rules, meaning it's relatively easy to get on long-term care relative to other states. And what I mean by that is for in other states, you have to both show that you're lower income and have lower assets. You really have to like spend down and eliminate your life savings to get on home care in most other states, not in California. And also, New York has created mechanisms or allowed mechanisms to exist like pooled special needs trusts and like Medicaid asset protection trusts that make it easier for middle class people who can afford a lawyer to enroll in Medicaid long-term care without spending down their life savings. What that means is that in New York, Medicaid long-term care is a little bit closer to being a universal entitlement and a little bit less like a aggressively means-tested program than in many other states. New York also doesn't have hard hours or enrollment caps. In many states, you can just end up on a wait list to access home care. In New York, for the most part, that doesn't happen. If you're eligible, you get home care. New York also has made a policy decision to have relatively high wages in its home care program. I emphasize relatively, like I would not be able to live on those wages, and I don't know how people do it, but relative to other states, instead of having, 12 or $14 an hour payments like in Pennsylvania, New York has a wage floor that's in the 1950 or $20 an hour range. And and the result of that is that more people are willing to provide home care, which means that more home care is provided, right? In many parts of the country, even if you qualify for Medicaid home care, you may not be able to access it because there's just no one willing to do it for $12 an hour. In New York, many more people are willing to and do it. So those are all policy choices. I also think the growth in Medicaid long-term care spending in New York is driven by the managed long-term care program, which, as I described, creates an incentive basically for managed care organizations to find new Medicaid enrollees and encourage them to join the program. Um, that I should say that doesn't necessarily mean anyone is breaking the rules, right? This is about what I described at the beginning of the call, that it is a real judgment call and complicated to define who truly needs long-term care. Um, the incentive to find people who may not have considered that they would be eligible for Medicaid long-term care, or to find their family members who have been caring for them informally and say, have you thought about Medicaid, is really strong in the MLTC program. I think that has driven a lot of growth. And also, uh, New York in 2015 loosened rules for family caregivers in CDPAP, meaning expanded the types and categories of family caregivers who could provide CDPAP. And that also tends to grow the program because many people who might not be comfortable with inviting a stranger into their home to take care of them or to take care of their parent, might be willing to do that work as a relative, right? And so I think it's really clear what set of policies decisions we've made as a state that have caused us to have a really large long-term care program. And I think other than MLTC, these are good policy choices. And yet, there's a concern, which is New York spends so much more than every other state. So what's up with that? Well, obviously it's a values question, a judgment question, but one thing I always like to point out about New York State long-term care spending is that long-term care is the one place where the average US state actually spends too little on healthcare. In every other category, in hospital care, in how much we pay doctors, in administrative costs, and prescription drug prices, the US spends by far the most of any developed country. But on long-term care, we're actually way below average. This chart is just we spend about $1,000 per person per year on long-term care, and the average OECD country spends about 40% more than that, almost $1,400. And so I think there's an argument to be made that what a civilized country would do is provide a broad, flexible, middle class long term care entitlement. And that New York has been moving in that direction in the past decade. And that is mostly something to be celebrated, even as we do have to take a look at some aspects of the program, like managed long term care, and reconsider how they've driven spending and what that means. Um, um, these are important questions because we're at what I think is an inflection point in the history of long-term care and especially home care policy in New York and in the US. So I said at the beginning of the call that for about 40 years, from 1980 to 2020, you could not find a politician or a healthcare wonk in the United States who didn't think we should spend more on home care. It was hard to spend more on home care because it's hard to tax the rich and it's hard to pay for stuff. But the consensus policy view was we spend too much on nursing homes. Need to spend more on home care. Home care saves money. Home care is great. We love it. Um, in the past couple of years in New York State and nationally, that has ceased to be true. We're in the midst of a sort of home care backlash, where both the governor and also the Dr. Oz and the federal administration are saying, no, 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 this is bad. They're understanding the problem in terms of Medicaid fraud or sort of poorly justified and documented accusations of fraud. But those don't have a lot of merit, but the policy environment around them is important. Um, I, I think the fraud question, um, there's always fraud in Medicaid. There's always fraud in any healthcare program. But like I said, I think there's no not fraud doesn't explain why New York spends so much on Medicaid, and also there's no need for some secret explanation. We've made a set of policy choices that are expensive because we decided they were a good idea, and so the question sort of answers itself. And so I think the fraud question is a red herring. I do think there are really important policy questions for us to consider as we respond to respond to federal attacks and also to fiscal pressures within the state. Um, One of those is, do we want home care? Do we want Medicaid long-term care to be a universal entitlement? Or do we want it to be a needs tested, means tested thing that you can do only if you don't have any relatives who are willing to take care of you and you've spent down your life savings and you have $0 in your bank account. To me, the answer to this question is very, very clear. I think that it's an enormous burden on individuals and families to provide to get long-term care. It's something that almost everyone will need at the end of their life, and that many people need throughout their lives. It clearly should be an entitlement. Um, I think there's a question that's but and I mentioned that because I think one of the political situations in New York long-term care is that we are sort of running a quasi-universal entitlement long-term care program, but we've never said that we want to do that. And people don't really understand that that's what it is, right? Like it's like until they need it, people are like, "Oh, Medicaid? I can't be on Medicaid. I'm middle class," and so forth. And so the result of that is that we have a program that's like as expensive as a universal entitlement, but that doesn't have the political support and understanding of a universal entitlement, right? Like if we manage to achieve universal childcare in New York State, then no one will be surprised that it's expensive. We'll say, yeah, we spend more on childcare because we provide universal childcare. That's what we decided to do. And so I think thinking through that question of like, do we want it to be universal? What does that look like? And how do we talk about it is important to the future of home care. I think also, to what extent should family caregivers be expected to provide care for free is a question that is wide open. I think when Governor Hochul, for example, talked about the CDPAP program being a fraud, I think what she sort of meant in her heart was that it's a program that pays you to take care of your own mother, and shouldn't you friggin' want to take care of your own mother and do it for free as out of a sense of obligation? Dr. Oz has been saying the same at the federal level. We have these Medicaid programs that are paying for people to sit at home and take care of their parents. And so the sort of alternative to having a really expensive home care program is the uh, the women will do it for free model of long-term care finance. And we need to decide sort of, do we think that is realistic and fair? Or should we be explicit that it's not and that we expect to pay people? I think at that level, I have no trouble deciding what I think about it. But I do think there's a range and spectrum. There's an enormous amount of informal care that happens. Anyone with aging parents knows this, that and how we want to support family caregivers, it may not be that they want or we want them to become like home care workers who do that as a job. It may be that we want to find other ways of supporting that are less intensive. And so I think the question on family caregivers is a big question for New York home care. And then I think the third one, which is the spiciest from my perspective, is um, nursing homes in the US are such a nightmare that and they're so abusive and sort of dangerous and bad for people that we went really, really far in the other direction and said people are going to stay in their home where they already are and they're going to get one-on-one care there. I think it's really important for people to have that choice. I also think sort of talking to people about their own aging relatives and thinking through experiences in my own life. I also think that non-nursing home communal based care, so stuff like social adult daycare, assisted living, home care integrated and senior housing, can be a more effective model than that one-on-one care. And I think that's an interesting policy direction to explore because it has the potential to be more efficient in some cases and to improve job quality and sort of job variety for home care workers vis-a-vis, when compared with the model that we largely use, which is one-on-one care in the home. And so thinking about like, given that to the extent that we do want a universal entitlement that pays family caregivers, can we think more about how we want that care to be delivered and how it relates to someone's life in their broader community? So, okay, that's what I've got to say. We didn't talk about a lot of stuff. This is my apology slide about all the stuff we didn't talk about. But I can leave that up while we do Q&A. Um, and yeah, I see Trina and yeah.
Okay, I'll be gentle. I just want to say consumer direction as a program, consumer direction, consumer directed personal assistance used to be called patient managed home care in 1979, 1981. When it got like codified into law was really 1995, but prior to that there were like pilot programs that played around with this idea of patient-centered, patient controlled home care, home attendant, patient, whatever. There were variations of this program at local districts and pilot programs. It started with the disability community, and it feels really dangerous to say this because I don't want to. I'm part of disability community and disability history, and I really, I volunteer for the New York City Department for the Aging. I'm involved in at aging services, senior disability services, but I just want to clarify for, I don't know, a little bit of, maybe it's because it's Disability Pride Month. I just want to push this narrative for, or at least present it. It was the disability community that started CDPAP in the first place. And quite frankly, when we started it, 1979, 80s, 90s, it was never initially about family members and neighbors or friends. It was about um, putting ads up in a local library or a newspaper ad. Um, I am a disabled individual. I am authorized for 84 hours of home care. I'm interviewing people who can be my personal assistant, sort of acting as your own home care agency. Um, and it eventually did open up in a good way. It should have. The world has evolved. The 70s and 80s was about independent living rights, but now we're more in a world of interdependence, and we recognize we need assistance to all survive, right? Um, in this world that we're living in. So what I just want to say is I just want to respect that lineage of the consumer directed personal assistance program that came from hiring people that we could then say, you know what, I'm interviewing you, and we're not a good fit. So goodbye. Sorry, you're not hired today, but you're
Yeah.
hired. Okay, you're hired, and here's how
Trina,
I'm so sorry. Oh, the the reason why I'm mentioning that is because CDPAP is so politically hot right now,
hmm
and it's scary. Um, it's scary the heat that the program that we created is under such um scrutiny that so many of it, and and I'm not I how do I say it? Because
I'm so sorry, Trina. Can you
yeah,
wrap up in the next
sure,
few? Yeah.
yeah. What I want to say is that the reason why that's important is because um, I'm a disabled individual who contributes to my local community, to my local economy, and my mother died, and she can't take care of me. And so family structures are not always the answer. And um, and that's why I'm emphasizing the the rights of those that are in the community to receive the services and supports that keep us engaged in our communities.
Yeah.
Um, I have, I don't
That's
know
really
how to say that. Yeah, I don't.
I do have to get
Yes,
off in about 3 minutes. Sorry. And I saw one other question. So I really, really appreciate I think that trajectory of CDPEP is a really important and strange one. And you should write about it at some point. But I want to get to, so Akash asked how important or not are counties in determining the size of the total Medicaid program? This is a great question that gets to an interesting historical trajectory in Medicaid. The In New York, counties once played a really, really significant role in Medicaid enrollment for all different sorts of Medicaid and also in Medicaid finance. So historically, New York and the federal government and the counties split the financing 50, 25, 25. So there was a huge role for the counties in funding the program and then also in doing eligibility determinations for the program. Today, that has become significantly less true at every level. The counties fund a lot less of the program as a share. Their contribution was capped in 2015. And they also play a smaller role in shaping eligibility. It is not entirely gone. New York City HRA has a significant role in home care. But I would say that the policy trend in New York for decades has been away from county administration toward state level administration. New York State of Health as an enrollment hub is sort of part of that story, and the state is in the process of rolling out similarly state level systems for other types of Medicaid. So counties are decreasingly responsible. And Bobby, oh hi Bobby. It's uh okay, these are, yes, Bobby is pointing out that Hochul is a hypocrite about home care, which is a very important point. Agree. Is there one last question and then I'll call it a night? Going once, going twice. All right. Um, well,
Quick question.
thank you all so much for coming to class two, session two of the FPI Medicaid Summer Boot Camp. Class three is going to be hospital finance and waivers. Those are things that are both likely to be extremely newsy over the next year. And so while all your friends are at the bar asking each other, what's up with the 1115 waiver? Will it be renewed? Or are state directed payments the same as provider taxes or different? Or is the local hospital going to close if it doesn't get enough VAPAP? You will be the one to answer them if you attend next session. Um, and I really appreciate you attending. All right.
Yep. Thank you so much.
Thank you. Have a good
Thanks,
night.
Michael.
Yep. Great.
Bye.
Have a good night, everyone.